There we go. Hi everyone, we're going to get started. Thank you so much for coming to share with us today. I do apologise right at the start. The place is even more, I'm trying to think of a nice adjective that says insane without being insane. The place is already more challenging today than normal. This is the last week of sitting. We know there's much to go on, so I know there's great interest in this topic. We've seen that over very many years, but I just want to let all of you know that have shown your interest by coming to share with us. While you may not see a whole lot of politicians here, but Katrina, thank you. Katrina Billick from Tasmania is here, and she should be acknowledged for that. Can I also acknowledge the traditional owners and pay my respects to elders of all cultures? Now, I've been told, and I do want to put on record my deep appreciation to Gretchen and all the work that she does, make sure this happens. So I'll do this right up front, Gretchen. Now, she's given me some notes about Claudia, and I don't normally do long introductions, and I'm not now, but I was really keen just to set the stage with just a little bit about Claudia so that we know when she comes to talk with us why she's done so. So you've been involved, Claudia, and tell me if this is all accurate, and then you can do it all again. I've been involved in palliative care for 13 years in a mixture of roles from clinical, policy, project and education perspectives, which covers just about the whole lot. You worked in rural palliative care, covering the area from Lithgow to Lake Collegio. Is that pronounced correctly? Cogelligo, actually, what you should have said was no. So it's an area I don't know. So that's New South Wales, is that right? I do know Lithgow because one of the guys from Roy and HG keep talking about Lithgow all the time. So I've never actually got there, but it's on my list because I want to see the Lithgow football team. Now, you're lecturing in palliative care at the University of Technology, and I know that they have a really great program there, and one of the ones that we celebrate because we need to have this kind of research on this issue across a whole range of institutions engaging the ongoing debate. I particularly want to acknowledge the people who've come to be here today. So I know the Rural Health Alliance is here, and I'm sure there are other organisations as well, but you know, guys from the Rural Health Alliance, there wouldn't be a show without you. So we don't think it's got credibility unless you're here. So, and I'll continue to say that in every group. So thank you so much for coming to see us. Thank you to Palliative Care Australia, because they're the ones who nurture this engagement with our Parliament. And what we've seen over the last 4 or 5 years, I'd say, don't you reckon? We have seen greater engagement in this place so that the issues around true palliative care, respect for this discipline, respect for the practitioners, I think those areas now are entrenched in the way we look at health and ageing in our country. And Anne Urquhart, another Tasmanian senator, I'm totally embarrassing her, has just walked into the room. So there you go. Thank you very much. Thank you.
Hi everyone, and thank you very much for coming along and for inviting me to speak today. Claire's given a bit of an outline of my background. So I haven't been working clinically in the rural setting for a few years, and I know there's a couple of organisations here who absolutely represent the needs in rural areas as well. So very happy to speak with you as well and for you to add anything in. I guess what I'm going to do today is talk a little bit about principles of care. So what are we actually aiming for? And I'm really going to reflect that in the national standards that we have for palliative care. I'm going to look a little bit at what are we doing well in the rural setting. So I'm pretty much always going to be looking at the rural, remote and regional settings, but I'll just call that rural for today. What are the priorities for change? And what I have done is taken that from some information that has come from a number of different sources and asked a number of CNCs to give me some additional input, CNCs being clinical nurse consultants, to say is this current and real information as well to the current day. I'm going to also tell you about 2 patients that I cared for clinically who I think show both the great things that happen in a rural setting for palliative care, but also the challenges that we do face when working in a rural setting. And of course there's then time for questions and discussion. However, framing everything, often people think palliative care really is about dying and about the issues to do with death and dying. Whereas really, as a person that's worked in palliative care for a long time now, it really is about life and how do we live with chronic, complex and life-limiting illnesses. So Dame Cicely Saunders, who was really the founder of the modern palliative care movement, I guess, says this quote, "You matter because you are you matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. And I think when looking at the work that we do, whether it be rural or metropolitan, it really is about how do we help people live well. And that's where there is a big challenge in some of the rural and remote areas where some services are seriously lacking. So helping people live well who don't always have allied health support and so forth can be quite challenging. So in Australia, we've got 13 national standards for palliative care or for end-of-life care. These were developed with stakeholders and experts and led by Palliative Care Australia, and are still very much used by services at many levels today. So these are relevant both for primary care, for whether it be general practitioners, whether it be for aged care facilities, or whether it be for specialist palliative care services. And it is a challenge when we look at these to see, are we actually able to meet these needs in a rural environment? Standard 1 is about individualised care planning involving the patient and the family. Standard 2 about holistic care, so really reflecting physical, psychosocial, cultural and spiritual needs. Standard 3 is around impeccable assessment. Standard 4 about coordinated care, and I think today we'll talk a little bit about those networks of care and coordination of care and how that does work between city and rural environments, and sometimes how it doesn't work as well as it ought to. Support for carers, being the carers like the family unit or non-professional carers. Standard 6 is around respecting patients' wishes really in that terminal phase of life. Standard 7 is really looking at the values-driven services, and do we have the values for the palliative care approach to care embedded within our organisations. Standard 7 is around formalised access to bereavement care, and this is something that really is incredibly variable in terms of access across Australia. Standard 9 is around building community capacity, and this is, I think, something that rural settings can really showcase. I think the community capacity and community support shown in rural scenarios is quite extraordinary. Standard 10 is about equitable access, and I think that's, again, a big challenge in a rural area. The stories I'll tell you shortly were tough in terms of equitable access to scanning, to radiotherapy and to other treatments. Standard 11 is around commitment to quality improvement and the implementation of evidence-based practice. Standard 12 around a skilled workforce. Again, a challenge when rural practitioners often have to be so generalist in nature, and how do we help them therefore have those networks for specialist input as needed. And Standard 13 around care for the caregivers, being the actual professional caregivers that are working in the field. So I guess when I think about the rural work that I did and what I learnt when I worked in the rural setting over a number of years was the importance of networks of care and support for practitioners, for families and for community members. And looking at the fact that you might have someone having very specialist care in a rural setting, and a lot of that support is provided through telehealth means or by the internet or by phone. So from a rural perspective, I was the nurse consultant, as Claire said, covering from Lithgow to Lake Cargellico. A lot of times I was sort of visiting fortnightly to the more remote areas, whether it be Condobolin or Lake Cargellico, and in between having extensive phone conversations with community nurses and general practitioners who really were the mainstay of care for patients in those communities. We do have specialist carers that come to those regions infrequently, sometimes monthly, sometimes less. And for those of you who know about palliative care and for people with chronic and life-limiting illnesses, we can't always plan their needs to be on that day, one day a month when the doctors are coming from Sydney. So really the GPs and the specialist nurses and the community nurses are working incredibly strongly together. Unfortunately, my experience in rural settings, I've never really had a network of palliative care allied health practitioners that I can work with. They've been more generalist allied health practitioners and often very restricted in terms of capacity to be able to provide a lot more or additional input from a palliative care point of view. And the comments I've had from a lot of the allied health staff were around wanting to build confidence in the space of palliative care as well. So that would particularly involve physiotherapists and occupational therapists, who I think when I've worked in city models of care, we've had huge access and often to specialist physiotherapists and occupational therapists. We've not had that in a rural setting, and it does, I believe, makes a big difference. So the other thing to say is that there are a lot of connected networks that are established. Some are very formally established and some less formally so. And I think sometimes there's a great risk that some of those less formalised networks can fall over based on a position change. So an example, recently was that there was a doctor that was visiting a rural area, and he was doing it because he was quite passionate about that area and he made that real commitment. He then retired, and there's been several years before we've been able to try and replace that position. And because there wasn't a formalised memorandum of understanding to make that happen, it's been a real battle for those services for many years, and therefore those patients haven't had that access. In saying that, there's always the phone. So I don't think we ever would leave a patient in great distress and not contact someone and get great support by phone as well. But some of those other connected networks that I realised at times didn't work well rurally was when patients did go to the city for treatments. There wasn't always great communication back to the rural setting to let us know what's happened, and that's a really vital issue, particularly for people from non-English speaking backgrounds and also for our Indigenous Australians who we didn't often have a lot of the information relayed back to us to continue care in an appropriate way. And so we would have to find that, which is always possible, but obviously hard in a time-constrained environment. So I guess I was just going to talk to you about two cases, two people that I worked with. There's Bernie and there's Norm, and in a moment I'll also get Norm to speak to you in a little audio visual that I've got. Bernie, and I think both Bernie and Norm show the great power that can occur in an innovative, creative environment in a rural setting. But also I was challenged by both of these patients in relation to the fact that we couldn't provide all of the medical options of care for them because they were only available in Sydney, and they weren't quite well enough to get that far. So Bernie was a 72-year-old farmer. He lived 40 kilometres outside of a rural town. He was diagnosed with lung cancer. He completed chemotherapy in a regional centre about 140 kilometres away from where he lived. He lived on a farm. And he was really well supported by his GP, who he'd known all of his life, and that GP remained critical to his care throughout all of his treatment. He had oncology visits monthly at the centre 140 kilometres away. As his disease progressed, so Bernie was very clear that he didn't want referral to palliative care for many, many months, and I heard about his care through a multidisciplinary team meeting run by a cancer care coordinator. And so I knew of Bernie, but I also knew very much that he did not want palliative care involved in his care. He was having problems with breathlessness, and the GP and I had spoken a couple of times about different ways you can manage breathlessness and the use of opioids in that way. So I was hearing sort of through the meetings that his disease was progressing, he wasn't doing as well, and he was really entering into a sort of phase of probably having a number of months to live. Still in that time, he was very clear that he did not want palliative care, and he kept saying that very, very clearly to his community nurses. His breathlessness was getting worse, and his chemotherapy wasn't working, and so the community nurses did sort of say, look, could we just get Claudia involved in your care? And I remember him ringing me actually and saying, look, I've been told to give you a call. I'm not going to call you a palliative care nurse. From now on, you'll just be called my pal, and that's all it'll be. And I said, that sounds great to me. So he organised in a couple of weeks that I'd be meeting him at his farm when I was out in that region. About 3 days later, I got a call from the community nurse to say that Bernie was incredibly breathless. His breathlessness had increased rapidly. And she wasn't too sure what to do. So she rang the GP, and he was running a clinic in another town. And this is where you see the real constraints, I think, in resources available to people at this time. So he was running a clinic in another town, wasn't able to get there immediately, but was wanting to be supportive and understand what was going on. I went out to see Bernie at his house, and I guess as I was driving there, I had sort of a few different provisional ideas as to what might be going on for Bernie. But I didn't think it was a normal pattern for him to be deteriorating that quickly in relation to his other illness. So I thought he may have an infection, he may have some fluid on his lung, he may have another particular issue. So when I got to his house, when I actually assessed Bernie, it did seem to me that he had a condition that we call superior vena cava obstruction, and it's kind of, it needs medical intervention if you're going to treat it, or you can be quite palliative in some ways and keep him at home. I'd never met Bernie before, and I remember coming into his room, sitting with him, having a chat for a little while. He looked like a very stoic man, very incredibly breathless, and he had a huge turkey that was in the room that made a lot of noise. But I remember being with him for a little while, and and this was what my concern was, that he had this particular condition. I rang his GP, and we talked through the positioning of his tumour and found that it was very possible. Now, in order to diagnose that, you really need a CT scan. To get that's 140 kilometres from where his farm was. And so I had that conversation with Bernie, who then said, yes, you know what, I feel for my mental peace of mind, I need to know exactly what was going on. So I do want to make that trip. But then if I need additional treatment, I don't think I want to go to Sydney. And so we had that sort of discussion, and we were able to get him to Orange, and he had his scan, and it did confirm that diagnosis. But what we weren't able to do was to give him radiotherapy or stenting or anything else in that regard, which perhaps he would have been able to have if he was in a city environment. Bernie chose, he said he wanted to go home to his farm, and he wanted to stay on the farm, and he had a very supportive family network. So we did get him home. We had all the sorts of equipment in place to try and have him well cared for in that environment. And a few days before Bernie died, he actually chose to go to the multi-purpose service because that's what he was wanting, to be in a hospital in the town where his farm was near. Again, I think a really positive part of what's in a rural setting is the multi-purpose services and the option we've got to work with them from a palliative care point of view, and often the beds that we can have in those services are more flexible than in fact what we can do in a city environment, which does make a big difference and is really helpful. His GP was flexible and fantastic, but the services or the structure to help him actually visit, you got to go, that's all right, to visit in the home setting really are not well in place. So Medicare is not particularly supportive for him to be able to travel those sorts of distances. And then Norm is a 65-year-old man, or was a 65-year-old man living in a regional town and diagnosed with motor neurone disease. Again, I won't tell you the whole story of Norm's care, but I guess what I learnt through Norm was motor neurone disease is a reasonably rare illness, and it was very hard for his medical and nursing team to know what is the best standards of care and how do we best manage this illness, because many of them had never worked with someone with that illness before. And I think that's, again, a difference that we see in a rural setting, where in a city, because of the bigger population, you're more likely to have met and worked with people with those illnesses. So Norm, for instance, asked for a referral through to the community OT, actually, and because the language wasn't used of motor neurone disease, he was placed on a very long waiting list that, in fact, was far too long for him from a therapeutic sense. But I'll let Norm talk to you now, because I think what he talks about is really resonates in terms of the theme of helping people live well.
If I was leaving a legacy and say what I would advise other people with motor neuron to do is to recognise the inevitable. Don't dwell on it, but recognise it. Make preparation for that time. Do your funeral arrangements if you want to. Write your letters, write your story if you've got time, and then let go of it and live every day as it comes. Get the best out of each day you can. Yeah. In the early days, I think, do everything you've been postponing. If you've got the chance, if you got the money, you got the chance, don't postpone anymore. It'll never be better than that time to do something.
And I guess when I think about Norm, he does talk about recognising, preparing and living. And my experience, I guess, in the rural setting was sometimes that the time to really help people prepare came in a bit too late. And so we were working with people as their illness had progressed already a huge they were very much at the end of life or terminal care, and it would just be good to be involved earlier. So are we really achieving the support for people that they need to help them live well? I think that there's definitely many instances of where we're doing extraordinary work and in very tough areas. I certainly worked very closely with the CNC from Broken Hill, who's got great partnerships with the Royal Flying Doctor Service, with other services that are just delivering extraordinary care. So even in tough scenarios, I think sometimes you hear of the most fantastic outcomes in those rural and remote areas. But it is hard. The resources are tight. I think the staff sometimes do look like this lady in the middle who's trying to sort of be a bit of a jack of all trades and trying to cover so many different roles. And in using that word from a staff point of view, that is inclusive of specialist palliative care, but also GPs, occupational therapists, physios, everybody working in that space, community nurses as well. But when I was reflecting on what do we do really well, I think in the rural setting, it really is very person-centred. The services know the person and the family, and that makes a really big difference to their care, because they do know. Like with Bernie's care, the services that were caring for him knew him very well, knew his wife very well, and were able to be very responsive in a personal way for them. They are very flexible services, so there are times where I've made referrals to services in Sydney. I've been told, well, for that community nurse, it'll be a 6-week wait. Whereas if I made a call to a community nurse in any rural setting, they were like, yeah, when do you need me to go? I'll make it happen, and they really did. They were very strong advocates both for patients and for families, and the advocacy that occurred was often happening both in the rural setting but also in the metropolitan setting where patients and families were going for treatments. I think they do create excellent networks. I think there is a risk at the moment that many of those networks are not formalised, and we need to be careful about that over time because there are many instances where that's falling down. Creativity definitely, I think, has been an incredibly strong part of what happens in a rural scenario. And an example would be that I was needing to get an oxygen concentrator out to someone in a very remote area, and at the time I wasn't able to personally take it. So the local butcher got in touch and said, I've heard this needs to happen. I've got a truck that'll fit everything. If you can show me how to work it, I can show the family. Now, I don't know if policy-wise this is all correct, but it worked really well for the patient. and it was a great thing for everyone. There's increasing information provision, but there are still times where GPs have said to me they didn't know about networks of support that are available, such as motor neurone disease associations or other associations that can support them in the care that they're delivering. And that was definitely the case with Norm. The GP and the specialist neurologist hadn't heard of those networks, so they weren't put in place for Norm, and he went home by himself, Googled what motor neurone disease meant and was, and made his own preparations without any support from anyone. And when he actually got carers involved from a professional angle who understood in great depth about motor neurone disease, unfortunately he was too unwell to still be able to get outside of his house and so forth. So there was a real lost opportunity in helping him live well at that time. There's a huge sense of community, and certainly from a staff point of view, sometimes they've said that's an amazingly positive thing and also quite a tough thing to work with. So going to Woolworths is often a long trip, where if you're the community nurse or the GP, you're often seeing many patients and families within that scenario. Innovation, I guess, goes with the creativity aspect. Teaching and learning, there's some really great programs that are rolled out now across many different areas within Australia for teaching and understanding palliative care, the palliative care approach or symptom management. I think what's really nice too is that there are some programs that are actually going to the rural setting to learn from the rural setting, and I think that's equally important. There's a huge amount for us to learn, and I certainly learned a lot from really expert practitioners working across the rural regions. From an Indigenous awareness point of view, I think in some services, again, we are very culturally competent and doing very well, and there are other services where we could improve on that in terms of the collaboration and meaningful engagement with communities. It's definitely an area of ongoing, a need for ongoing prioritisation in that area. The cancer care coordination model seemed to work really well in the area that I was working in, and from talking with counterparts across Australia, it certainly seems to be a helpful and important role. And it does make me wonder about whether some form of care coordination role for people with palliative care needs may also be useful. for people who don't necessarily have a cancer diagnosis. But generally, care is done, I think, very well. People do care in those scenarios. It's not an anonymous type of contact made in health. People know each other and they do really care and want to do the best they can. But I guess when I was reflecting on where are the priorities for change, and really in the theme of palliative care is everyone's business, I think we have to continue to really improve access to specialist palliative care across the regions. So really looking at availability and funding for specialist services. In many regions, we don't have specialist palliative medicine positions that are able to be filled, and oftentimes what we therefore do is link via phone. Again, additional specialist palliative care nurses, but I particularly think specialist allied health services would be incredibly useful in those regions. Out-of-hours support is required, and in some areas they have a great out-of-hours structure, in many areas they don't. And an area that I've been particularly worried about for many years is around succession planning in the rural setting. Many of the staff that have been there for a long time, do an extraordinary job, but ensuring that there is someone to step into their shoes is not always available. And then paediatric palliative care is an area that I think the models of care for that have been improving a lot over recent years. But again, the exposure to children dying in the rural setting is fairly infrequent, which is a good thing. And therefore, the staff feel quite underconfident in caring for those children, and we need to look at how do we best support them. I think definitely the ongoing idea of improved networking with primary care colleagues, so whether that be GPs, community nurses or other people working in primary care roles, to truly enable optimal end-of-life care is equally vital to the specialist palliative care provision. So these are just a few dot points I thought of, but things like funded opportunity for case conferencing and so on. I know Medicare does provide rebates for GPs, but the allied health services aren't included in that, which does make it very hard for them to be able to dedicate that time to actually be part of that care planning. In some areas we do have palliative care beds in multi-purpose services. In many other areas they're not identified as palliative care, and in some ways that does matter because access can be limited if it's not identified. But in other ways it doesn't. I think there are some limits in terms of the length of time that we can use those beds, and being able to free up some of those barriers, it would be incredibly useful. Many GPs spoke to me about the fact that they were very happy to actually do home visiting and support to aged care facilities in the rural setting, but the actual travel time to get to and from farms or from patients' homes throughout the towns is a real factor and is definitely not reimbursed through the current framework. So, for instance, to get to see Bernie, I would have loved that GP if he'd had time to come and be there with me, because I needed a medical diagnostician to work alongside me on that day. Now, if he'd been in town, he probably would have come, but he would have probably had 3 hours out of his day. And I think that the Medicare rebate gives you something like 20 minutes to half an hour or something. So it's sort of doesn't represent that at all. I think there's a real role for pharmacists in our rural towns. Every time I've worked with the pharmacists in those towns, they're amazing conduits. They've got a huge amount of information and knowledge, and they're really quite happy to be used as that connection point. And have often said to me, please promote us more in that role. We're very, very happy to be providing information and providing that connection. Ongoing education is also really vital. The other area that we really struggled with was social care support. This isn't unique specifically to rural services, but it is harder, I think, in rural services. So, for instance, the HAC services, the Home and Community Care Services, there was a period where we were told we weren't really able to use HAC services for palliative care, and then we could again. But what I've also been told from a rural point of view is that there's not the number of people to assist care is just not there, and so we need to think a little bit more creatively about how we can actually put in social care in place to keep people at home if that's where they're wanting to be. There's a model that's been used in New South Wales called PEACH, which is working off the extended aged care packages, but looking at them from a palliative care point of view, and I wonder whether there's scope for us to think about that in rural settings. to actually enable some creativity in how that package comes together. We used to have funding for palliative care patients through the Carer Respite Centre to enable actually having nurses to stay overnight. Not a huge amount, but they could stay, say, 2 or 3 nights, and it really made a big difference for carers at home. And my understanding is that funding was withdrawn, and I'm not sure if it's been reinstated, but I remember that from a rural angle being an incredibly a mainstay in actually allowing families to cope with and manage that end-of-life care. We do need, and again this is feedback from recent CNCs, improved processes to support advanced care planning and the use of advanced care directives. I'm being told that particularly some of the ambulance protocols and some other hospitals are still not recognising advanced care directives, and therefore some of that planning work that is done is not being seen through to fruition. And in line with that is some policy support for managing for when patients do die at home, how that life can be pronounced extinct and that body be managed well, so that if there's not a doctor available to do that certification, how that person can still be appropriately cared for. So in a rural setting, if the doctor is not available to come and see the person, in some settings they're actually having to ring the police, and that's clearly not an optimal outcome for the patient and the family. So again, policy support to be more supportive in that way is really important. And also, I mentioned earlier the need for improved collaboration and engagement with Indigenous communities and organisations, and really working with a lot of the Close the Gap campaign work that's happening in relation to the Aboriginal health workers that are working in communities, and how can we best hear what their needs are from a palliative care point of view. As the Indigenous population is clearly very diverse, and as is their I guess what they're wanting from palliative care services, and so we need to be able to hear that from across Australia and actually then be able to action it appropriately. So that was where I was going to end. I'm very happy then also for questions and discussion. I don't know if do you want to go straight into that, or so any questions or discussion points? Or you can refute anything too. Yeah, Gordon. Yeah, he, from the very beginning part of his illness after diagnosis, sort of wanted to beat his illness and didn't want to think about end-of-life care and dying. And even as his illness was progressing, he knew it was progressing, but he maintained that that's where he was at from a mindset point of view. And it didn't matter so much at that point, in that his GP was in touch with me anyway, and we were talking about how can we best manage his breathlessness. So that as Bernie did deteriorate, he then, I think, realised when he wanted me and our service. I think definitely terminology is difficult, and sometimes some patients don't want to acknowledge and use the words palliative care. And so sometimes we, talk about symptom management, expert symptom control and so forth to get a foot in the door. And then you can establish that relationship and move forward from there. Yeah. But it is an issue, but what was really good for him in the rural setting was he had very experienced clinicians around him from a generalist angle who knew how to link in and get support as was needed. Yeah. Yeah, my views are face-to-face does seem to be more powerful overall, but you can also do a huge amount by phone. I actually haven't done a lot in the space of telehealth or internet connection, but generally in the rural setting, I guess there are healthcare providers often somewhere near the person, and so often it's about working through them, whether that be the community nurses or the GPs. So when you're not there frequently, so for instance, a lot of my patients in Condobolin, I was only getting out there once a month or so, and the key people to them were the GPs and community nurses, and I was a bit of an adjunct, and that was fine. It seemed to work well. But I think when you do have that opportunity for face-to-face time, you really need to use that to establish the trust so that when you're on the phone, there's an easy rapport in that way. Yeah.
From a nursing perspective, the succession planning that you saw was lacking. What do you see any action in that space?
Yes and no. So in some, definitely people are aware that it's an issue and trying to work out how do we best encourage other nurses to come into the space of palliative care. And the difficulty is in many areas there's only one funded position for specialist palliative nursing, and in a way that makes it hard to mentor another person over time. Because there might be a community nurse who has a whole other caseload of work, and so they can't necessarily spend extensive time with the other person and learning from them. So that can be difficult. I think generally, certainly at an undergraduate nursing level and in other areas, we're trying to increase the amount that we're teaching around palliative care and the palliative care approach, and we have great resources to do that through, there's a program called the Palliative Care Curriculum for undergraduates and so forth. And so hopefully we're opening minds to this area of care a little bit earlier. I think also if we can actually help our community nurses and other people working in those generalist roles to feel really comfortable in working with people who do have complex illness or who are dying, then in a way they will take the main amount of that work, with the specialist nurses being there to tap in and support them. And in some ways that works, in some areas that works beautifully, and then there were some other areas where the community nurses just said, I only really see a person dying every 1 or 2 years. I feel really quite scared about it. And so I would be doing very basic palliative care with them and supporting them in that, and that was fine from my perspective. But I guess our model that we try and talk about in Australia is that the generalist nurses would be feeling okay to care for people who have generalist requirements. But in the rural setting, I'm not sure that that's yet the reality.
So do you find that different in an aged care, residential aged care setting?
Yeah. I think there's still more upskilling required in the aged care setting. I mean, some of them do palliative care really beautifully and others less so. And so some of the rural aged care facilities in rural regions that I worked in, again, did extraordinary care, and then there were some areas that were really needing a lot of help. So I think it's a transition in process at the moment, yeah.
Hi, Jenny Johnson from Rural Doctors Association. So just following on from that, I'm interested in your comments about what works well and what could be done to improve rural doctor skills in these areas, and also what we need to pass on in training to our medical students and registrars who are going out in rural areas.
Okay. I think what GPs generally said to me across, a little bit in line with the last comment I made, but what GPs said often to me across that region, so I was just in New South Wales, was their exposure to people with complex illnesses was infrequent. Working with people who were ageing and frail was frequent, and they felt much more comfortable there, but people with cancers and motor neuron disease or other neurodegenerative disorders, they found quite confronting. So I think being able to enable them to know where to go when that occurs is just fundamental. So if we think about the neurologist and the GP who cared for Norm, neither of them knew that there was motor neuron disease New South Wales, who could have actually set up a whole host of other care supports for him and supported them in information provision. The other thing is around the conceptual shifting from, I guess, acute care and always trying to cure, and being able to understand when it is appropriate to start having discussions around advanced care planning, advanced directives, end-of-life care, and that still remains variable in terms of how often that's done well. So for your undergrads, it's definitely around communication and that discussion around those complex, hard places to talk about. Yeah.
Firstly, my apologies for being late.
Okay.
As Shadow Minister for Seniors, this does sort of come into my responsibility. And one question that's I really can't find an answer to is, at any given time, what percentage of
people who die need palliative care?
I think it depends. I mean, so it would depend how you define palliative care. So I think everybody needs end-of-life care, good, excellent end-of-life care or palliative care as they're dying.
Can I say to
Yeah.
be specific? In my electorate, for instance, we've raised a lot of money and we have very good palliative care. And we've just got a new facility at our hospital, and we have people who come on a daily basis. There are people who need pain management. There are people who need a range of assistance because of the nature of their illness.
Yeah,
Excuse me. Everybody needs, I understand that statement.
yeah.
But from a point of view of making death not agonising, what percentage at any given point in time
I-
needs that?
Yeah,
How big is that?
how big is the problem? I probably can't give you a percentage as such, but in terms of how big is the problem, I think everybody who's dying ought to have the principles of care that we discussed at the very beginning, which is around holistic care and being informed and having impeccable assessment and expert symptom management. Sometimes that can be done beautifully at the level of a nursing home or at a GP level. And I guess your question is, how often is it not done well at that level and needing specialist input and expert symptom management?
There was, I've previously been Minister for Aged Care. There was what I thought appalling practice that people would be sent from an aged care facility to hospital to die.
Mm.
And they didn't want them dying in their facility. That's
Yeah.
basically what I'm saying.
Okay.
I think there's a much bigger understanding now of the need for palliative care to be part of that process.
Yeah,
But there are
absolutely.
only 170,000 people in aged care facilities.
Yeah.
I think, what, how many people die a year? It's less than are born. So what do we have are born? About 250,000. I think something like 180,000 people die a year.
Yep.
So of those, the people who have the things you're talking about, motor neurone disease, cancer in its last stages,
Yeah.
those sorts of things, I still can't get a handle on. People who ought to be having the priority, I suppose.
So there is some information around who is likely to die from an expected death in Australia, and I can't remember the exact statistics there, but Palliative Care Australia has some information on them, which is, so I guess anyone dying from an expected death ought to ensure that they ought to have the facilities available to them to have a good death. Now that can be needed at a specialist level or a non-specialist level. I agree with you that I think in aged care the change over the last 10 years has been profound in terms of people initially definitely being sent to hospital frequently and often not sent with plans in place, so they were very much into the acute system, going on to ICU and other trajectories of care that were not appropriate and not comforting for the patient or family. And I think that is changing. It's still not ideal. And there are still, in the hospital systems, generally, there's still that real push for acute and the curative approach, particularly in the city region more so than the country area, I would say. So from a rural angle, they seem to sometimes get that better, I think. So I don't know if that sort of answers your question, Brom. I don't know if Patsy or Yvonne want to...
I'll send you through some statistics that we've put together. But I think what Claudia was saying is incredibly relevant, that everybody deserves, a palliative approach for life expectancy, obviously. But for different disease trajectories, obviously, there's different expectations. But I can send you through some data.
Thank you.
And I think, Senator, part of the complexity of all of this is that often it's not just the disease, it often depends upon what capacity the community and the family and the resources around them have. So it's sort of this many, many factors that sort of need to be taken into account. But the point about what we need is systems where we are really good at assessing when that person needs that extra level of care that we can get from there. And so it's those sorts of things that I think we need to aspire to be able to identify when we need to make sure that they've got access to it when they need it.
Can I have a last question?
Sure.
The distinction between or the merging of the concept of hospice and palliative care.
So I guess from my point of view, and again others might like to chime in, but so the hospice really is sort of, for me, an inpatient unit, a specialist palliative care unit that we tend to now call specialist palliative care units. But many of our older Australians do call them hospices and still see them very much as being for terminal care. And I think in, probably the late 1970s, 80s, 90s, we were using them more for that purpose. And so for our older Australians, can be quite scary for them when they see a hospice being as purely about terminal care, where really now sort of hospices or specialist palliative care units should be about symptom management, terminal care, rehabilitation if it's appropriate, respite care as well. So that I think they ought to be much broader. And really, again, founding that principle of caring for someone who's got a really serious and chronic illness that is life-limiting but needs a whole host of support, as Patsy mentioned, to connect them into the right care so they're well supported, whether they be in the inpatient unit at home or in their nursing home. Yeah. Any other? No?
Thank you. Can you join me on
That was fantastic. Thank you very much, Claudia. I think there were a couple of really key points there that came out of what Claudia was speaking about. One of them is obviously access to care, which we already know it is not uniform across the country, and it's especially difficult when we move out into rural and remote areas. And I think Claudia's point there about access to allied healthcare is something that we don't think about very much. There's some good programs in place to get doctors especially out into the rural areas. We haven't focused enough on allied health workers. That's something we really need to. Keeping in mind, of course, that palliative care is a multidisciplinary approach. We really need to keep that in mind. And it's obviously not only palliative care patients who require allied health specialists, but it's something that we need to focus on. The other thing that I really took away from that, Claudia, was your comment about one of the patients needing to travel 140 kilometres for chemo. All of us know people who have had chemotherapy who may only have to travel 5 kilometres, and even how hard it is on their and their family in those circumstances. To have to travel that far from home really brings home the whole story, doesn't it? So I think we can do a lot better, but I think the story that you've told is fantastic, and I can't add anything to your wonderful points that you added in at the end there, which was great. So can you join me again? And can I tell you, there's a fact sheet on your table there, which was developed largely by the Rural Health Alliance. And if you have any further queries about that, please speak to us or speak to Rural Health Alliance. I know Gordon will be happy to jump up and answer questions as well, won't you? But once again, join me in thanking Claudia. And we haven't scheduled another Friends meeting at this point in time, but there should be one later in the year. But in the meantime, there's a tiny little thing called a National Palliative Care Conference, which happens to be happening at the beginning of September. So from the 3rd to the 6th of September, put it in your diary now, because it's the best conference on the planet. And trust me, I've been to many. And it really, really is good. So do come along, and you can speak to Gretchen about the wonderful details of that. Okay, thank you. And thank you, Gretchen, and everybody else.